Rntcp, or the Revised National Tuberculosis Control Programme, is the state-run tuberculosis control initiative of the Government of India. It incorporates the principles of directly observed treatment short course, the global TB control strategy of the World Health Organization. The program provides, free of cost, quality anti-tubercular drugs across the country through the numerous primary health centers and the growing number of private sector providers. History = Need for a revised strategy = India has had an ongoing national TB program, NTP, since 1962. In order to overcome these lacunae, the government decided to give a new thrust to TB control activities by revitalizing the NTP, with assistance from international agencies, in 1993. The revised National TB Control Programme thus formulated, adopted the internationally recommended directly observed treatment short course strategy, as the most systematic and cost-effective approach to revitalize the TB control program in India. Political and administrative commitment to ensure the provision of organized and comprehensive TB control services was obtained. Adoption of smear microscopy for reliable and early diagnosis was introduced in a decentralized manner in the General Health Services. DOTS was adopted as a strategy for provision of treatment to increase the treatment completion rates. Supply of drugs was also strengthened to provide the assured supply of drugs to meet the requirements of the system. Large-scale implementation of the Rntcp began in 1997. Expansion of the program was undertaken in a phased manner with rigid appraisals of the districts prior to starting service delivery. The initial 5-year project plan was to implement the Rntcp in 102 districts of the country and strengthen another 203 short-course chemotherapy districts for introduction of the revised strategy at a later stage. The Government of India took up the massive challenge of nationwide expansion of the Rntcp and covering the whole country under Rntcp by the year 2005, and to reach the global targets for TB control on case detection and treatment success. The structural arrangements for funds transfer and to account for the resources deployed were developed, and thus the formation of the state and district TB control societies was undertaken. The systems were further strengthened and the program was scaled up for national coverage in 2005. This was followed up with Rntcp Phase 2, developed based on the lessons learned from the implementation of the program over a 12-year period. The design of the Rntcp2 remained almost the same as that of Rntcpi, but additional requirements of quality-assured diagnosis and treatment were built in through schemes to increase the participation of private sector providers and also inclusion of DOTS Plus for MDR-TB and also offering treatment for XDR-TB. Systematic research and evidence building to inform the program for better design was also included as an important component. The advocacy, communication and social mobilization were also addressed in the design. The challenges imposed by the structures under NRHM were also taken into account. India achieved countrywide coverage under Rntcp in March 2006. The Rntcp was built on the infrastructure and systems built through the NTP. Major additions to the Rntcp, over and above the structures established under the NTP, was the establishment of a sub-district supervisory unit, known as a terabyte unit, with dedicated Rntcp supervisors posted, and decentralization of both diagnostic and treatment services, with treatment given under the support of DOT providers. Components of Rntcp, the directly observed treatment, short course DOTS strategy along with the other ingredients of the Stop TB partnership are implemented as a comprehensive package for TB control. DOTS strategy adopted by revised National TB Control Program initially had following 5 main components: 1. Political will and administrative commitment. 2. Diagnosis by quality-assured sputum smear microscopy. 3. Adequate supply of quality-assured short-course chemotherapy drugs. 4. Directly observed treatment. 5. Systematic monitoring and accountability. In 2006, STOP-TB strategy was announced by WHO and adopted by Rntcp, whose components are as follows: pursuing quality DOTS expansion and enhancement, addressing TB HIV and MDR-TB, contributing to health systems strengthening, engaging all care providers, empowering patients and communities, enabling and promoting research. Many of the initiatives like developing and piloting the feasibility of national airborne infection control guidelines, developing and piloting strategy for practical approach to lung health are the examples of initiatives taken by Rntcp under the comprehensive strategy of STOP-TB. Diagnosis of pulmonary TB under Rntcp. Diagnosis is made primarily based on sputum smear examination. X-rays play a secondary role in the standard diagnostic algorithm for pulmonary tuberculosis. Sputum smear microscopy, using the Ziehl-Neelsen staining technique, is employed as the standard case-finding tool. 2 sputum samples are collected over 2 days from chest symptomatics to arrive at a diagnosis. In addition to the test's high specificity, the use of 2 samples ensures that the diagnostic procedure has a high test sensitivity as well. As a national health program, Rntcp pays more attention to the sputum-positive pulmonary tuberculosis patients than people with other, non-pulmonary forms of the disease. National Strategic Plan TB India, with progress in achieving objectives in the 11th Five-Year Plan and defining newer targets of universal access to TB care, newer strategies have been developed as a comprehensive national strategic plan under the 12th Five-Year Plan of Government of India. The following thrust areas were identified: strengthening and improving the quality of basic services, further strengthen and align with health system under NRHM, deploying improved rapid diagnosis at the field level, expand efforts to engage all care providers, strengthen urban TB control, expand diagnosis and treatment of drug-resistant TB, improve communication and outreach, promote research for development and implementation of improved tools and strategies. The National Strategic Plan was prepared through a consultative process involving a wide cross-section of the stakeholders and experts in the program. More than 150 experts from various disciplines and organizations were invited for the deliberations for developing the plan. Innovation and consensus were the highlights of the process adopted for development of the National Strategic Plan. Strategic vision to move towards universal access. The vision of the Government of India is for a TB-free India with reduction of the burden of the disease until it is no longer a major public health problem. To achieve this vision, the program has now adopted the new objective of universal access for quality diagnosis and treatment for all TB patients in the community. This entails sustaining the achievements of the program to date, and extending the reach and quality of services to all persons diagnosed with TB. The objectives of the program proposed in the plan are: 1. To achieve 90% notification rate for all cases. 2. To achieve 90% success rate for all new and 85% for retreatment cases. 3. To significantly improve the successful outcomes of treatment of drug-resistant TB cases. 4. To achieve decreased morbidity and mortality of HIV-associated TB. 5. To improve outcomes TB care in the private sector. Proposed strategies in the National Strategic Plan 2012 to 2017, case finding and diagnostics, early identification of all infectious TB cases. Improved integration with the general health system, and leverage field staff for home-based case finding. Improve communication and outreach, screening clinically and socially vulnerable risk groups for TB. Develop improved sputum collection and transportation systems. Deployment of higher sensitivity diagnostic tests for TB suspects and decentralized DST services, catch patients already diagnosed through notification from all sources, improved referral for treatment mechanisms, and deployment of laboratory and private provider notification, patient-friendly treatment services, promptly and appropriately treating TB, increasingly guided by DST. Making DOTS more patient-friendly through increased communitization of DOT. Pilot incentives offsets for patient costs to help patients complete treatment and better monitoring through information technology. Improving partnerships between public and private sector, establish Indian standards for TB care which can be used to engage providers using existing private treatment and improve care with some public sector support and supervision. Research will guide improvements in regimens and delivery systems. National Treatment Committee (TWG) for review of regimens, all treatment-related technical guidance, scale-up of programmatic management of drug-resistant TB. Developing network of C&DST laboratories and strengthening of reference laboratories, decentralized DST at district level for early MDR detection, improved information system for PMDT, manpower support for additional workload by aligning with NRHM health blocks and rationalization of number of patients per STS, improved drug management of second-line anti-TB drugs. Scale-up of joint TB-HIV collaborative activities. Activities will aim at early, rapid TB diagnosis with high-sensitivity tests for HIV-infected TB suspects and ART for all HIV-infected TB patients, with transport support. Integration with health systems. Integrating the Rntcp with the overall health system will increase effectiveness and efficiencies of TB care and control, which has been depicted in the picture. In rural areas, the Rntcp can focus integration through the National Rural Health Mission. In urban areas, the Rntcp can integrate through private sector and the evolving National Urban Health Mission. What will National Strategic Plan achieve? Control TB. Compared to today's activities, success will accelerate decline in incidence and prevent 22 lakh TB cases, reduce TB deaths by 75%, and save 17 lakh lives from TB, contain MDR-TB, avert 1 lakh MDR cases and reduce incidence by 50%, quicker diagnosis of more TB patients, more effective treatment in future, direct economic expenditure on TB cases prevented, and leadership for India, sustain India's global leadership in TB treatment and control. Treatment categories and drug regimens. Standardized treatment regimens are one of the pillars of the DOTS strategy. Isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin are the primary anti-tubercular drugs used. Most DOTS regimens have thrice-weekly schedules and typically last for 6 to 9 months, with an initial intensive phase and a continuation phase. Based on the nature severity of the disease and the patient's exposure to previous anti-tubercular treatments, Rntcp classifies tuberculosis patients into 2 treatment categories. H. Isoniazid, R. Rifampicin, Z. Pyrazinamide, E. Ethambutol, S. Streptomycin. Patients who weigh 60 kg or more receive additional rifampicin 150 mg. Patients who are more than 50 years old receive streptomycin 500 mg. Patients who weigh less than 30 kg receive drugs as per pediatric weight band boxes according to body weight. Notes: new categories includes former categories I and III, previously treated as former category 2, others include patients who are sputum smear negative or who have extrapulmonary disease who can have recurrence or resonance. Public-private partnership under Rntcp. In India, a sizable proportion of the people with symptoms suggestive of pulmonary tuberculosis approach the private sector for their immediate healthcare needs. There is need for regularizing the varied anti-tubercular treatment regimens used by general practitioners and other private sector players. The treatment carried out by the private practitioners vary from that of the Rntcp treatment. Once treatment is started in the usual way for the private sector, it is difficult for the patient to change to the Rntcp panel. Studies have shown that faulty anti-TB prescriptions in the private sector in India ranges from 50% to 100%, and this is a matter of concern for the healthcare services in TB currently being provided by the largely unregulated private sector in India. Second phase of Rntcp. In the first phase of Rntcp, the program Euro unregistered trademark's focus was on ensuring expansion of quality DOTS services to the entire country. The future holds a different set of challenges including MDR-TB and HIV-TB. The Rntcp has now entered its second phase, approved for a period of 5 years from October 2006 to September 2011, in which the program aims to firstly consolidate the gains made to date, to widen services both in terms of activities and access, and to sustain the achievements. The second phase aims to maintain at least a 70% case detection rate of new smear-positive cases as well as maintain a cure rate of at least 85%. This needs to be done in order to achieve the TB-related targets set by the Millennium Development Goals for 2015 and to achieve TB control in the longer term. Today India's TB control program needs to update itself with the international TB guidelines as well as provide an optimal anti-TB treatment to the patients enrolled under it, or it will land up being another factor in the genesis of drug-resistant tuberculosis. See also, Public Health System in India, Tuberculosis, Epidemiology of Tuberculosis, Tuberculosis Treatment, Tuberculosis Diagnosis, the Global Alliance for TB Drug Development, Stop TB Strategy, Global Plan to Stop Tuberculosis, Multi-Drug Resistant Tuberculosis. External links: 1. Tuberculosis Control India's homepage on Rntcp, TRC Chennai Tuberculosis Research Centre, Chennai, NTI Bangalore. The National Tuberculosis Institute, Bangalore, Stop TB. The Stop Tuberculosis Partnership website, History of TB Control in India, WHO page on TB. WHO's Global TB Programme, What is DOTS? A Guide to Understanding the WHO Recommended TB Control Strategy -1999, Rntcp at a Glance, Tuberculosis Control in India, Rntcp Annual Report, 2007 Status Reports 2007, Anurag Bhargava, Lancelot Pinto, Madhika Pai. Mismanagement of Tuberculosis in India, Causes, Consequences, and the Way Forward. Hypothesis 9, E7 doi, 10.5779/Hypothesis V901.214. Gyanshankar Mishra, Jasmine Mulani. Tuberculosis Prescription Practices in Private and Public Sector in India. National Journal of Integrated Research in Medicine 4, 71/76. References: Gyanshankar Mishra, SV Corpad, Jasmine Mulani XDR-TB, An Outcome of Programmatic Management of TB in India. Indian Journal of Medical Ethics 11, 1. 47-52 Jan. Available online at http://216.12.194.36 Index of Particle 932/2179.